Good afternoon, everybody, and delighted that you have joined us here with your lunch. You're all multitasking as you listen to our session. So we'd like to say a big thank you to Nestlé Health Science for this satellite symposium at the 15th Annual Congress of ESSD. And the topic, or the title of this symposium, is Navigating the Challenges of Dysphagia, Malnutrition and Sarcopenia in Older Adults. My name is Julie Regan, and I'm delighted to be joined here today by Professor Elisabeth de Waal, who has come to us from Brussels in Belgium. So thank you, Elisabeth, for joining me here. So we'll move to our first of our two talks in this symposium, and I'd like to introduce my topic, which is Presbyphagia, Understanding Age-Related Swallowing Changes in Older Adults. And as I mentioned, my name is Julie Regan, and I am an associate professor in speech and language pathology based in Trinity College in Dublin, if you hadn't guessed already from my accent. So my topics for my talk are firstly presbyphagia. What is it and why do we need to prioritize it? Then the prevalence, some of the causes and the features of presbyphagia, the interventions and how we might approach treating presbyphagia in the future, and some priorities for future research. But first, we're all very aware of the fact that our international population is aging at a very fast rate. Within Europe, in 2001, 16% of the population were over 65. 20 years later, in 2021, that had shifted to 21% of our population. Looking at it in a different way, in 2001, 3.4% of our population were aged 80 and over. And in a short period of time, that had shifted from 3.4 to 6%. And you could all imagine the impact that that would be having on healthcare services. And this issue isn't something that's restricted to Europe. As you can see on the right-hand side, it's a global change in our population across continents. If you look at the navy countries, and where the population is 60 years or over, is at over 30% of the population. Looking at it in a different way, you can see the red subgroup on the bar charts. Back in 2009, that the red subgroup was relatively contained, whereas if we look at projected percentages of those over the age of 80 years plus over time, it's going to be a significant component of our population. So we really need to think about future-proofing our dysphagia services. So how does this aging population impact on us as a society at large? It's going to impact on our workforce. It's going to have financial implications in terms of our economy. From our perspective, and of huge relevance to this Congress, is the impact it's going to have on our healthcare services, both acute and out in the community. And also, professionally speaking and personally, it's going to impact hugely on family structures. And that's of relevance too in terms of caregivers and how much pressure there's going to be on other people to care for individuals with either presbyphagia or dysphagia. So the message really here is that we need to invest in preventative intervention to try to minimize the impact that presbyphagia or dysphagia will have on future populations across the globe. So let's look specifically at presbyphagia then. It's defined as a disruption to swallow function with age in the absence of any other underlying disease. So it's typically asymptomatic. There's minimal to no effect on our oral intake, on our overall health, or on a person's quality of life. Presbyphagia alone doesn't cause dysphagia, and they're certainly not synonymous terms. What does happen is that a person who has presbyphagia has a reduced swallow functional reserve associated with the aging process. And I guess this means that if there is the introduction of a stressor or a trigger, that then can mean the person then goes on to develop a dysphagia. So you can see it's very important for us, both as researchers and clinicians, to be able to differentiate between presbyphagia and dysphagia so that we can prioritize people for treatment. To look at it in another way, we can have a presbyphagia-dysphagia continuum. So we might have an individual presenting with presbyphagia who doesn't have any clinical complications for their swallow and as a result may not need intervention and certainly not diet modification. But with the introduction of a trigger, which could include the likes of an acute infection like a UTI that causes a hospitalization, it could include a change or an introduction of a new medication or another clinical complication. And that can disrupt what's already quite a weak equilibrium. Our bodies are amazing, and we manage to acquire these natural compensatory mechanisms, and that also goes for the swallow. But when that is disrupted, that is when a person might develop symptoms of dysphagia. And it is then that the safety and the efficiency of the swallow might become impaired. And that's when these clinical complications such as dehydration and malnutrition might present. So thinking about the prevalence of presbyphagia, it's been quite varied across research papers, and one of the reasons for that is the different evaluation methods that have been employed across studies. And I guess the more instrumental the assessment, the higher the prevalence rate. There was a nice systematic review and meta-analysis published recently for adults over the age of 60 years, and 19 studies were selected for analysis. And in this study, the prevalence of presbyphagia in older adults was at 31%. But of the studies, 10 used an invasive or more instrumental method, which increased that prevalence to 44%. And how do we define aging or old? And I just think for all of us, as the years go on, we have a different definition of what old is. But it's interesting to see the varied definitions in the dysphagia literature. And for those studies that have had a look at the impact of aging on the swallow, that has ranged from just the age of 50 years, which I think some of us take great offense to, and that has moved to the age of 65 years. But what's really a positive thing is that more and more there's been a focus on the oldest old, because as our population is aging, and people are I suppose, surviving for longer periods of time, it's important to know over time the implications on the swallow. So let's have a look now at the features of presbyphagia across the different phases of the swallow. Firstly, looking at the oral and the oral preparatory phases. Obviously, the loss of dentition is going to have a big impact when it comes to mastication of more solid bolus. There's also a decreased taste and smell, reduced oral sensation, reduced salivary flow, a perceived mouth dryness, a reduction in lingual strength, which we'll refer to again later, and a reduced strength of the masticatory muscles. When it comes to the pharyngeal phase, the features that have been documented in the literature include a reduced pharyngeal stripping wave, reduced pharyngeal pressures, larger pharynx volume and reduced pharyngeal wall thickness, as described by Malfenter et al., impaired tongue base retraction, reduced anterior hyoid excursion, delayed and reduced extent of UES opening. But what's so interesting is how people compensate with age, and as a result, there tends to be a longer duration of UES opening. Likewise, as a compensatory mechanism, we tend to have a longer swallow apnea duration with age, again, a potential compensation. And another feature is reduced bulk and sensitivity of the vocal cords. It's so important to also consider the esophageal phase of the swallow now that we appreciate the strong interrelationship between the pharynx and the esophagus. And different features in this phase include esophageal motor activity declining with age, reduction in amplitude of esophageal contractions, delayed esophageal transit time as observed during video fluoroscopy esophageal screening, and altered pressure in the lower esophageal sphincter. But the big question is, do all of these changes to the swallow lead to increased penetration and residue associated with presbyphagia. And we don't seem to have a conclusive answer based on some of the contradictory evidence that is in the literature. There are a number of studies that have found that, yes, there is increased penetration or aspiration and residue associated with aging, and other studies have really found no impact on swallow efficiency or on swallow safety, which really makes it more difficult for us in clinical practice to be able to differentiate between presbyphagia and dysphagia. What may be the case in some of these studies that some of the participants maybe have some undiagnosed other contributing factors that could be impacting on their swallow performance. Either way, we do know that the bolus spends longer in the pharynx and is in close proximity to the open airway before the swallow is initiated, so there's certainly an increased risk of penetration and aspiration. There are many different contributing factors to presbyphagia. These might include the change in taste and olfaction, some changes to cognitive function and neurological deterioration, that reduced sensation in the oral cavity and pharynx and reduced saliva production, the increased number of medications that people tend to be on with age, respiratory changes, changes in cervical spine and curvature, and one contributing factor I do want to focus on is that of sarcopenia. So we know at this point that sarcopenia is an aging syndrome characterized by progressive and generalized loss of skeletal muscle, mass, and strength. And it's one of the main causes of disability in older adults. And based on the initial graphs where we look at that aging population over time, it's something that we really need to bear in mind from a clinical perspective. Sarcopenic dysphagia is now a term used to describe a swallowing disorder caused by sarcopenia of the whole body skeletal musculature and swallowing muscles. Typically, it's the tongue and the pharyngeal musculature that is affected in people with sarcopenic dysphagia, and age and malnutrition are strongly related to sarcopenia. It's been positively associated with dysphagia, and Suzuki et al. Found a statistically significant relationship between the presence of sarcopenia and dysphagia in women beyond the age of 65 years. And decreased tongue and lip strength are strong indicators of sarcopenic dysphagia, which might help us to inform some preventative intervention studies within the future. So despite our increasing awareness of the different features of presbyphagia across all of the different stages of the swallow, there's a limited number of bespoke screening and assessment tools specifically for older people. And perhaps this is something that is worth us focusing on based on the projected increases in people above the age of 80 years of age going forward. A PhD student from Trinity College Dublin carried out a scoping review recently looking for the swallow screening tools being used for older adults in residential care settings internationally. And 19 quantitative studies were included in that review, and he found that 13 different instruments are being used for swallow screening in residential care settings. The modified water swallow test was the most commonly used, but the 3-ounce water swallow test, the Yale, and the Googing swallowing screen were identified as the instruments with the best clinical accuracy. The reported prevalence of dysphagia in this setting ranged from 15 to 70%. So it seems as though a screening tool that is validated and developed based on the nuances of this specific population are lacking and would potentially be beneficial going forward. Looking then at some instrumental findings, presbyphagia has been studied on video fluoroscopy, including this study by Garand et al., published in 2022. In this cross-sectional study, they looked at age-related changes in swallow physiology using the MBS-IMP across 195 healthy older adults. And the components of the MBS-IMP that older adults had worse scores for were tongue control during bolus hold, higher laryngeal movement, laryngeal closure, pharyngeal contraction, and again, pharyngoesophageal segment or UES opening. And what was very encouraging was to see this systematic review published in New Zealand, which looked specifically at the oldest old, so those people over the age of 85 years. And their findings in this systematic review is that the features within this cohort tend to be an increase in delay of swallow onset, increased bolus transit times, increased duration of UES opening, increased pressure above the UES, whereas reduced UES relaxation pressure, and a reduction in the resting pressure at the UES. There have been some investigations using FEES too, which is ideal. FEES as an evaluation could be very beneficial, given that endurance over the course of a mealtime might be very important for the older population. So in this particular study, 64 people over the age of 70 years were evaluated using FEES, and 32 of the 64 individuals did present with alterations to their swallow. And pharyngeal residue was the main issue observed. And in this case, the airway was rarely compromised. What was also interesting to note was that presbyphagia was an independent predictor of reduced nutritional status, which sets us up nicely for Elizabeth's presentation shortly. So just to take a totally different perspective on the aging swallow, there have also been some high-resolution manometry studies looking at the effects of aging on swallow pressures. And in this particular study by Cock and O'Mary, where they evaluated, or they carried out a systematic review looking at pharyngeal high-res manometry and esophageal manometry in the older population, they found lower UES resting pressures, decreased UES relaxation compared to younger groups, increased pharyngeal contractility, which perhaps is to compensate for changes in the extent of UES opening, decreased distal esophageal contractility, and reduced lower esophageal sphincter relaxation. And findings from Corinne Jones et al. Aligned with this. 98 healthy adults were included in their pharyngeal manometry study, and they found that age was associated with tongue-based maximum pressure, tongue-based maximum variability, and the upper esophageal sphincter, and specifically integrated relaxation pressures. So there do seem to be some patterns across studies in terms of the main issues at play. The tongue seems certainly to be an important component, as is UES opening. So what can we as a speciality do to target presbyphagia if we're thinking about this increasing aging population and how we can future-proof our research and our clinical services? It's certainly my opinion, and I'm sure I share it with all of you, that the dysphagia community should be prioritizing research to better understand presbyphagia and to establish how we can prevent that progression or that shift on the continuum from presbyphagia on to a dysphagia. And perhaps prophylactic intervention has a role. There's certainly impressive research being published looking at the role of prophylactic intervention in clinical populations, but perhaps we should be looking at healthy older adults and thinking about preventative care. And maybe that might include education so that people are aware of the fact that there are changes to their swallow, incorporation of oral hygiene programs, and perhaps some exercise-based interventions. It's interesting to hear Maggie Lee talk about the difference between strength training and skill training, and based on her discussions, it seems as though there might be a role for some strength training within this population, given the fact that sarcopenia seems to play a significant role. But likewise, skill training, the likes of respiratory swallow coordination, could be very important when it comes to swallow safety. There have been some studies looking at preventative swallow exercises in healthy older adults. 15 studies were included in this recent systematic review that was just published this year. 10 randomized controlled trials included, and certainly a vast range of different preventative interventions. My favorite was the karaoke intervention. And I think that, in fairness, was conducted bearing in mind socialization and adherence. What they did find, or the findings across these different studies, was improved muscle function, so certainly encouraging initial findings, but the impact on swallow safety and efficiency to date is less clear. What I find interesting is the potential role of whole body exercises on swallowing. A review article was published only 2 years ago in the International Journal of Language and Communication Disorder, looking at exercise or whole body exercises and their indirect impact on the swallow. And again, the results here were quite interesting. So it's encouraging to see this year the publication of some articles, I think, from the United States, looking more specifically at the role of whole body exercise on some clinical populations, including Parkinson's disease. And certainly from an efficiency point of view, wouldn't it be great if we're working as a multidisciplinary team alongside physiotherapy colleagues and taking outcomes to see if whole body exercises were having an impact on the swallow. So, some research priorities for us to bear in mind. As we can see, the international population is aging and there's potential for big pressure on healthcare services and on our dysphagia services. So we have an opportunity to proactively intervene out in the community to take pressure off our acute healthcare systems, to try to reduce the number of older adults who are progressing from presbyphagia on to dysphagia, where they're at higher risk of clinical complications. Perhaps some longitudinal research in healthy older people would be beneficial to investigate the role of a preventative swallow intervention on swallowing, and that could be the combination of some skill and strength training. Likewise, based on some of the systematic reviews that have been published, there's such a range of outcome measures being used that the development of a core outcome set specifically to the topic of presbyphagia could make our research that bit more efficient and conclusive. So my take-home messages: there are changes to all phases of the swallowing with age. There are a number of big contributors to presbyphagia, including neurological changes and sarcopenia. Presbyphagia should not be problematic unless a trigger leads to dysphagia. Instrumental evaluations have also given us a better understanding of the biomechanics of swallow and the changes that occur with age. And let's work together, whether the societies, ESSD, DRS, the Japanese societies, maybe ESPN, or at some of our multidisciplinary societies. The ideal would be if we could all work together to develop some research and establish evidence base for some prophylactic interventions. Thank you very much.